All right, here we go. So these are the main things that we're going to learn about today. How transplantation is changing over time in number, the types of transplants, donors, and for which diseases. We'll talk about how transplantation is improving outcomes and expanding indications. How clinical trials help new ways to treat and care for patients and be the match resources for you and your family. So there's two major types of transplants, and you've been hearing a little bit about that on our first two speakers. You've heard about allogeneic, you've heard about autologous. So what's an autologous transplant? Autologous transplant, shown on the left side, means that you're using your own stem cells. The patient donates their own. And typically they're harvested either from, which means harvest, taken from, collected from. Traditionally it was the bone marrow. But over time, we found out how we could get stem cells from the bloodstream. And that's why you may hear blood and marrow transplantation. So the cells are typically taken, they're frozen, that's called cryopreservation, and stored. And then when it's time for your transplant, they're thawed and given to you by your vein, kind of like a blood transfusion. Allogeneic transplant means that someone else is donating to you. They're giving you healthy stem cells. That may be from a family member. It may be someone that's unrelated to you, and that's where Be the Match comes in, because we help find unrelated donors. It may be from the bone marrow or the bloodstream, again. And then in the 1990s, we found that we could use umbilical cord blood stem cells for transplant. And so parents donate the umbilical cord blood, and you can take stem cells out for that. So the number of transplants is gradually growing. I did my first transplant in 1984. And you can see then that the number of autologous transplants started rising. And does anyone know what that blip up is? In autologous, the blue? That was for breast cancer. Do you remember when we were trying to see if transplantation might help patients with breast cancer? We hoped that it would, but then clinical trials showed that actually didn't. And so we really no longer do transplants for breast cancer. That green line is the number of allogeneic, so using a donor cells. And so about 14,000 autologous transplants are done in the United States now every year, and over 8,000 allogeneic. So 22,000 transplants a year. That's quite a few. We're helping a lot of patients. There's been a lot of advances made over the years. The top line shows you a little bit about what the transplant course is about. First, we identify which patients, when you're talking with your doctor, for which transplant's an option for you. And very careful selection. Is it the right time? Are you healthy enough? Is your disease under control? You identify a source of stem cells that might be your own. It might be that you need a donor. And then you typically undergo what's called a conditioning regimen. And that may be chemotherapy, sometimes some radiation is added to that. But that's to get your body ready for the new cells, to get rid of any remaining blood cancer, to make sure that when those new cells are given back to you, they're going to grow real healthy. And they're given on day 0. That's your transplant day. You're counting down, day -7, day -6. Day 0 is your new birthday. And then you wait for engraftment. That's when the cells are growing in, whether or not they're your own or someone else's. And that's kind of a critical time for you. You kind of had this chemotherapy, you're needing some transfusions, you're worried about infections. But then you gradually, they engraft, they grow in, and you're on your way to recovery. But we have to worry about relapse. You've heard that about that. Up to a quarter or a third of patients may have their disease come back. We want to make sure you have a really good quality of life. So there's been a lot of changes. Autologous transplants now are often just given as an outpatient. Everyone who needs an allogeneic or needs a donor, there's so many options now that we can find a donor almost for everyone. We know the best time to do a transplant when your disease is under control, and that's earlier than later. You heard about conditioning regimens. They're really being fine-tuned, and it's allowing more patients to have transplants. Graft-versus-host disease is something that when those allogeneic new cells grow in, they say, oh, different person. Graft-versus-host disease. And that remains the biggest problem that we've had. I thought in 1984, when I saw a patient that had graft-versus-host disease, that it would be gone in the next 5 years. We would figure it out. We've made a lot of advances, but we're still trying to figure it out. I'm going to tell you about that. We found new ways to treat complications, so the more people survive the transplant. We're figuring out ways to keep it from coming back. And then I'm going to end with a point about survivorship. So let's first talk about donors. I envy the match, right? So what if you don't have a matched sibling and you need a transplant, an allogeneic transplant? About 30% of people will have a matched sibling. That means HLA matched. Take a blood sample or swab from inside your cheek, and you have the same kind of human leukocyte antigen proteins, HLA matched. What if you don't have a matched sibling? 70% of people, and this is typically used for leukemia, all right, won't have a matched sibling. Well, there's a lot of options, and that's where Be the Match can come in and help find a donor. That may be an HLA-matched unrelated donor. We've just completed a trial for mismatched unrelated donors. It seems very promising. Some of you may have heard about a haplo or half-matched transplant. I'm going to tell you about that, or cord blood. So what if there's no matched sibling? Many institutions that are represented here, Be the Match, help support what's called the BMTCTN. That means a Blood and Marrow Transplant Clinical Trials Network, a national network of transplant centers that have joined together to make advances as fast as possible for patients who need a transplant. So if there's no matched sibling, we have developed at Be the Match a way to look at your HLA type and say, you know, it's really likely that over 90% of the time we're going to find you a matched unrelated donor, and that's the way we'll go. But what if there's a less than 10% chance? Then the transplant center will say, we're going to pick the best option we think for our patient, and we're going to follow all these patients and see what is the best donor and how patients do. So what's this haplo thing? How many of you have heard of a haplo transplant? Anybody? Oh, this is really big. This is big. This is where the field has really been moving over the past 5 to 10 years. And it really came about that we just saw that less than 1 out of 3 people will have a sibling. And it can take time to find an unrelated donor. So this means that it is half matched. Only half. And what's really nice about this is this increases the chances that you'll have a family member be able to donate to you. Okay, so how does that work? So here's the mom and here's the dad. Okay, these are called haplotypes, and these are really the makeup of your genes in your body. And everybody has kind of 2. That's the way to think about it. And here, mom is red and mom is a light blue. Dad has a green and a dark blue. You get 1 from mom and 1 from dad. Each one of you sitting here got 1 haplotype from your mom, you got 1 from your dad. Okay? So mom and dad had 4 kids in their family. Okay, they're all siblings, and that patient needs a transplant. So in the old days, what we would say, you got to have a perfect match. Well, 1 sibling is red and green. The patient's red and dark blue. The other sibling's kind of that teal blue and green. And the other sibling's that teal blue and blue. So none of the siblings match. Brothers and sisters came in, they got their blood tested, buccal swab, and they wanted to donate for their brother, and they don't match. But if you only need 1, a half match, look what happens. Mom or dad, if they're healthy, they could donate. Gosh, got a couple siblings that could donate. And this patient has a very healthy college-age son and daughter. They could both donate. So it increases the options. So how's that possible? If you can do a half match, why haven't we been doing it for 30 years? Well, here's what it is. When you don't match, we worried about graft-versus-host disease. That new graft was only half match, came in, so oh my God, this is a stranger. This is a stranger. I'm going to have to attack the stranger, or else I'm out of here. I'm not going to grow in. So what came along, and a lot of this was done at Johns Hopkins, is that you give chemotherapy after you give the new cells. Now, isn't that spooky? I spent all my time figuring I'd give chemotherapy before I give the new cells back, all right? But this is a drug called cyclophosphamide, Cytoxan. And if you give it for a couple small doses, a couple days after you infuse after transplant day. It can help get rid of the cells that cause the graft-versus-host disease, but otherwise the cells grow in just fine. So this has really been a major advance. They're still newer than the old way of doing transplants. They look incredibly promising. So what has happened if we're doing more haplos? Has that affected what other types of transplants we're doing? So if you take a look, unrelated donors, that blue line, is kind of leveling off. Matched sibling, kind of stable, but look at those haplotransplants. They're really rising in number. And what we're seeing is less of a use for cord blood. Okay? So this really opens up options for patients who need an allogeneic transplant. And so that's why I said that almost everybody who needs a transplant from someone else can get one in this day and age. Well, let's talk about conditioning regimens a little bit. You've heard about that. It allows more patients to undergo a transplant. In fact, you saw the slide earlier that the most common reason to have an auto using your own stem cells is that bright green. Okay? And there's new conditioning regimens that week before you actually get your own cells back, that's really helping patients do better with transplant and live longer. The other indication, the reason to do an autologous transplant, is for lymphoma, and you're going to be hearing about that later. What about using someone else's cells? The most common is acute myelogenous leukemia, and you're going to hear about that. And you just heard about myelodysplastic syndrome, ALL, acute lymphocytic leukemia, much more commonly an acute leukemia of childhood, Hodgkin's lymphoma, and then we'll be talking about some of the other diseases in a few minutes. But here's what's going on with autologous transplant. Look at multiple myeloma. I think you saw this earlier. From 2000, when there was about 1,500 transplants done in the United States every year, now over 9,000 for multiple myeloma. So that is the biggest indication for autologous. And you heard earlier today, it's better to do it up front, right? Lymphoma, you're going to be hearing about a little bit later today, and that also is a very common indication, a little bit more over 4,000 a year. Here's allogeneic using a donor. So acute myeloid leukemia. This really remains the only curative therapy for AML, so it's really important about the timing of transplantation. And then the others are kind of stable through the years. Acute lymphocytic leukemia, MDS has grown a little bit, and some of the lymphomas, typically we use auto transplant and reserve an allogeneic transplant if the disease comes back, or it's really high risk where we think an autologous transplant is not going to be helpful. But here's something that's new with different types of conditioning regimens, that we now are exploring allogeneic transplantation for sickle cell disease. You know, sickle cell disease has really been a major, major struggle throughout the world. And we are now almost quadrupling in the last decade. That means four-fold increase in the number of patients that are undergoing transplantation for sickle cell disease. That's amazing. Can we cure what typically causes young people to have strokes, pain, infections, die at a very early age? Now may be able to cure. And there's a variety of studies ongoing for sickle cell disease. I think this is really exciting. This one's asking if a matched sibling or an unrelated donor transplant offers a patient improved survival than if they don't undergo a transplant. And this one's looking at haplo, half-matched, for patients with sickle cell disease. And this includes children and adults. Let's talk about this graft-versus-host disease a little bit more. This really has been a major problem over the years. When I was a youngster, that I had a patient who had such severe graft-versus-host disease. Pat, I don't know if you've ever seen this, but it can affect early on the skin, the liver, the gut. It was affecting the skin overlying the eyeballs when blinking, and had to close the eyes, really, to sew them shut to help prevent the blinking. That's a very, very severe case. But graft-versus-host disease, these new cells getting happy in a person's body, can be both early on after transplant, or it can bothers some people, a small percentage, small number of people for many years. So this has been a major focus of transplant physicians. So there's been a lot of work about which is the best way to prevent acute graft-versus-host disease. Acute is that early form of this graft-versus-host disease. And the standard is this top bar, tacrolimus and methotrexate. You don't need to know the words, but that's just kind of been now the standard. But now, there's early work that shows that if you add that cyclophosphamide to it, it may be better. So this is a trial called Progress. I love the name, right? Progress. To look to see how we can prevent graft-versus-host disease. But what if you've already developed acute graft-versus-host disease? Are there new ways of looking at this? And there are. I think this is really exciting. So this is patients who are newly diagnosed, have acute graft-versus-host disease, and the standard way of treating this is with prednisone steroid. But the University of Michigan, under the direction of Dr. Reddy, has done some great work looking at this drug called human alpha-1 antitrypsin, AAT. And it looks like it really reduces inflammation throughout the body. So this is how a clinical trial is often done, is that you compare this new therapy, but you still get the standard, the prednisone, or you just get the placebo plus the prednisone. So when we talk about standard of care, you get the best known, but then in a clinical trial, you might have the option of getting something that might help. And so if patients respond to this, they'll go on and get some additional doses. So this would really be a tremendous advance for the field if this works. But what if you have this longer-term graft-versus-host disease? My gosh, it took until August of 2017 to have a new drug approved. I mean, it took that much time to find something to figure this out. And this is called ibrutinib, and it helps a lot of people. So this was a tremendous breakthrough, and it came about because of clinical trials. There's other things now that are being done that I've mentioned here, so work is ongoing for chronic graft-versus-host disease as well. What about how to prevent complications of transplant? This is really complex therapy. It requires a lot of thought, a lot of consideration, a lot of input by the patient, caregivers. Often patients getting an allogeneic transplant may be hospitalized for several weeks and then have to stay near the transplant center for up to 100 days after transplant to be really carefully monitored for complications. Well, there's been a lot of focus on this. So let's talk about a few things that we're looking at in terms of judging when a patient might have complications and how we can prevent them and how we can treat them. So you've heard a lot about older patients undergoing transplantation, right? And when we talk about older in the transplant world, I'm going to use the age of 60. And until 2004, we had strict guidelines at transplant centers. When I first started transplanting, the upper age limit was in the 40s. Then as those transplant doctors got older, we found ways to push the limit, kind of keep our options open. But now many transplant centers do not have an upper age limit. All right? So if that's the case, if a patient, and I'm setting in a clinic, how can I make sure that patient's going to be safe? Got to use a little bit of common sense, right? So that's where it comes in this what's called a comorbidity index. It just says, what other health issues do you have? And as we all age, we start having some health problems, right? We may have high blood pressure, maybe our kidneys don't work as well, maybe got a little diabetes. And so what we found out is other health issues may be much important than whether or not you're 59 or 62, okay? And so you saw this slide a little bit earlier, that increasing number of older patients, because we figured out ways to figure out who can safely get through a transplant, how to support, and how to reduce complications. And in fact, the 60-plus age group is the fastest growing population for transplantation. Think about acute myeloid leukemia. When I was growing up, I thought, we all remember the young patient that has two small children that has AML. But really, AML is diagnosed in your 60s. That's the most common. MDS in the 60s. So many of your blood diseases are diseases of older patients. So we've got to figure out a way to help older patients, and we've done that. And so if you're 60 and older, transplantation is a really viable option for you. Age alone is not the issue. It's the same thing for allogeneic. So allogeneic's a little tougher to do. You're using someone else's cells. But the same thing, no upper age limit now. But how can we predict which patient that's 60 years of age and older might have complications where we should say, maybe not? So in addition to looking at your heart, your lungs, the kidney, your liver, there's also this concept of whether or not you're frail. That's a nice word for saying, are you healthy enough to go through, are you frail? But things about how fast can you walk? How much can you grip? Have you been falling at home? Are you thinking clearly? Those might be really important things to look at. We also know you can take a blood sample. And is there a lot of inflammation in the body, which just means, gosh, something is really stirred up. Maybe they're going to have problems with transplant. But we also now know about quality of life. Is the patient depressed? And can we help with that before heading into transplant? So if you're depressed heading on, transplant's going to be tough to get through. Are you anxious? What's your physical function? And what's really great is that centers are developing clinics focused on looking at this and helping patients get in better shape before transplant. That's great. One program is called TOPS. I love that. And so this study is called the CHARM study. And it's going to be saying patients older than 60, let's do this really great assessment for frailty. Let's look at them after transplant, day 100, day 180 a year. In addition to just looking at complications, the usual things, and if they're alive and if they have graft-versus-host disease, we're also going to see what transplant did in terms of how they're able to just do their activities of daily living. Get up, take a shower, get dressed, do your grocery shopping, get the kids off to school. How many needed to be admitted to a skilled care facility, needed rehabilitation? What's their quality of life like? So this is really opening up a new world to pay attention to our older patients and best judge when they're able to undergo a transplant and how we can help them get through it safely. And I wanted to also talk about infections a little bit. Infections can be a real problem for patients. I wanted to pick out one that has just changed dramatically. In the 1980s, there's this virus. Many of you have seen this virus as a kid. When you were 2, you had a runny nose, your mom wiped your nose. That might have been CMV, cytomegalovirus, CMV. So many of us have it. And what happens, it can start growing again after transplant when our immune system doesn't work. Okay? And so in the 1980s, if someone developed CMV, we didn't have anything to do for that patient, and they typically died. But now, not only do we have ways to treat it, we have ways to prevent it. And a new drug called letermovir is incredibly helpful in preventing this disease. So we've gone from a disease over the past 30 years that typically caused patients to die, that really now is getting really low on our radar. And we're starting to think about other less common infections and tackle them. So there's a whole different ways of treating viral infections, bacterial infections, fungal infections, and preventing them. And so the chances of dying from a transplant, an autologous transplant, is incredibly low. Many centers is 0 or less than 1. It'll never be 0. There's always something that comes up, right? Rarely. But allogeneic transplantation, 30 years ago, we might have a 30% chance that a person might die from a complication. And now we're down to the 10% or so range. It's not 0, but we've really made huge advances. And I want to finish by talking about, you've heard about relapse. That's always so disappointing when a patient comes to talk about transplant. You think cure, cure, cure. And then you have to have the discussion that, it might come back. It might come back. And so a huge amount of work is being done to help keep disease from coming back after transplant. That's what relapse means. And this shows you on the left side that how much disease there might be in the body. We try to do the transplant. This is here showing an allogeneic transplant, but this could also be auto. And we want to do it when you're way down at the bottom. You're in remission. That's the best chance that a transplant's going to help, right? When you don't have very much you have to get rid of with a transplant. So you've heard about maintenance therapy. You heard about lenalidomide to help keep multiple myeloma away. That's something we start right away afterwards. That's called maintenance, when the patient is still in the remission. We also have little special tests now to watch for what we call minimal residual disease. That just means a little bit that you can detect with really special tests. So now there's ways to watch for that and to get ready to do some more therapy before it starts growing. But unfortunately, some patients will be at the top, be going along, doing well, and their disease will come back. So there is research ongoing and trials ongoing to help prevent disease coming back at every single stage along here. Can't see any disease, watching for just a little bit, and more. And so you say, well, why just give everybody maintenance therapy? Because there can be side effects. It's always a balance, right? Do you treat, do you not treat? And so there's a whole bunch of things to help prevent disease from coming back. You're going to hear about acute myeloid leukemia, what we call targeted therapies, really trying to go after that very specific change in that specific patient's leukemia. You're going to be hearing about lymphoma. You're going to be hearing about a variety of ways for us to help prevent disease coming back. You heard about hypomethylating agents, HMA, and Dr. Khan's talk about MDS. It's also used in acute myeloid leukemia. There's a variety of, you've heard about cellular therapy. I mean, this is really exciting, so much that the Transplant Society changed their name to Transplant and Cellular Therapy. This means taking out specific cells from the bloodstream, either from you or from your donor. Maybe they're T cells, maybe they're natural killer cells. Maybe you change them into CAR T cells, and Dr. Stiff's going to be telling us a lot about CAR T cells a little bit later. I have a special interest in helping survivors. We are lucky that there have been so many advances made now that there are going to be 500,000 survivors in the next years. That's exciting, but we want them to live a good quality of life. And what you'll hear words about is called patient-reported outcomes. Yeah, it means asking the patient. How novel, right? Ask the patient. How do you feel? Did this therapy make you feel good, bad? How did this one make you feel? If they make you survive the same amount of time, pick the one that wasn't so bad and how it made you feel. And so this is the word of what we call quality of life, patients telling us. There have been tools developed where we can send it out to you by your iPad or your cell phone. We've built a complete electronic structure at Be the Match. So for every clinical trial, we're going to ask patients, what do you think about this? We know that as patients survive after transplant, they might have other health issues. And we're really determined to understand what we do during a transplant that causes those late problems and prevent them. So just a little bit of an advertisement. Our booth did not arrive. Scott's been looking for it. He even rented a car. I hear he's been driving around the Chicago area. He got our AV staff to help him find the booth, but it's not anywhere. But Scott is at the booth, and he will be happy to tell you some of this information. But we have a support center. We have resources in 11 languages. No question too big or too small. This is for autologous, allogeneic, for any type of disease. Give us a call. Patients and caregivers can connect through a Facebook page, and I think that's really helpful to support each other. And in 2017, we launched the Jason Carter Clinical Trial Program. And this is Jason. I actually helped take care of him at the University of Minnesota. He had ALL, and his parents were phenomenal. And when Jason's disease came back after transplant, they worked very hard to help work with the physicians in identifying clinical trials that might help save his life. And they donated and started a clinical trial program. Scott, who's here today, is a nurse specialist. It's in lay language and will help you find any clinical trial that you might be interested in. So what are you going to take home? Actually take to the break and then take home. Is transplants changing? I hope I've told you that's really evolved. Outcomes are better. Clinical trials have been phenomenal in advancing the field. And we're here to help you. And so let us know how and when and where, and we'll be there. So thanks very much.